Okay, in this technical review, we're going to deconstruct the mechanisms and treatment of obsessive-compulsive disorder. We'll be looking at the precise cognitive and neurobiological processes that actually define the condition, and then the clinical interventions designed to interrupt them.
This quote, it really captures the central paradox of OCD, doesn't it? Intellectually, the person often knows, and I mean knows, their fears are illogical. But that rational insight is completely powerless against what is essentially a faulty neurobiological alarm. This disconnect, it stems from a breakdown in what we call yeda sentience, that intuitive feeling of knowing that something is complete or just right. In OCD, that signal is broken.
So let's start with the foundational element of OCD, the intrusive thought. You see, the core clinical issue isn't the presence of these thoughts. It's the process, the mechanism, by which a totally universal mental event becomes a source of just profound suffering.
Now, this is absolutely critical to understand. Intrusive thoughts are a normal, universal part of being human. Our brains produce constant, unfiltered mental events. For someone with OCD, a bizarre or disturbing thought just gets noted and dismissed as meaningless mental noise. The pathology of OCD begins with the appraisal of that thought and the reaction to it.
So here is the crucial turning point, when a random intrusive thought is met with alarm, with distress, and with a real effort to suppress it. The brain completely misinterprets that resistance. It flags the thought as a significant threat, and it assigns it an importance that it simply does not have. This is the very first step that separates a passing thought from a clinical obsession.
All right, so how does a thought, now that it's been falsely deemed important, get stuck? Well, this process involves cognitive feedback loops, and specifically a dysregulation in what's called the cortico-striato-thalamocortical loop, or the CSTC loop for short. The best way to think of this is as the brain's cognitive filter and its gear shifter. In OCD, this whole circuit becomes hyperactive, and it prevents the person from being able to disengage from a thought or an impulse.
That initial reaction of distress is driven by the amygdala, which is the brain's primitive alarm system. We call this first fear. It's an automatic physiological response. And you have to remember, the amygdala is not sophisticated. It can't tell the difference between a real, external threat and a disturbing internal thought. It just fires. It floods the body with sensations of danger, which in turn makes the thought feel critically important and incredibly real.
So this slide here, it maps out the precise sequence that leads to fixation. First, a universal thought occurs. It's met by the amygdala's first fear. In response, the person tries to suppress it, but this triggers something called the ironic effect, a well-documented phenomenon where the effort to not think about something makes it pop up even more frequently. And of course, that increased frequency then serves as false proof of the thought's importance, cementing its status as a clinical obsession.
This escalating distress leads directly to the next stage, the compulsion. The brain, now desperate to reduce the anxiety produced by the obsession, starts searching for a solution. And that perceived solution, that's the compulsion. It can be an obvious overt behavior or a hidden, covert mental process.
This table helps provide some clinical clarity on the core components. You have the obsession, that's the intrusive trigger. Then the compulsion, that's the neutralizing act. And this is critical, rumination is a form of mental compulsion. This really clarifies the whole misconception of pure O. There is no such thing as OCD without compulsions. In so-called pure O, the compulsions are simply covert mental acts, things like mentally reviewing events, seeking reassurance in your own head, or trying to solve the intrusive thought.
And it's this internal dialogue that keeps the whole cycle going. The worried voice, that represents the intrusive, distressing nature of the obsession. And then you have the voice of false comfort, which represents all those bad coping strategies, the compulsive attempts to suppress, argue with, or get reassurance about the thought. These actions, they might provide a tiny bit of relief in the moment, but ultimately they just reinforce the obsession's importance, which just fuels the worried voice and keeps the whole loop going.
Okay, this all leads us to the gold standard treatment, exposure and response prevention, or ERP. And let's be very clear, this is not just facing your fears. It is a precise behavioral intervention designed to systematically break the very cycle we've just outlined by targeting the relationship between the obsession and the compulsion.
The therapeutic logic of ERP is that to rewire a fear circuit, you have to activate it first. So the individual has to willingly and deliberately lean into the discomfort and the anxiety that's triggered by their obsessions. This purposeful engagement is absolutely necessary to provide the brain with new learning that can override that established fear response.
Now, the clinical goal of ERP has actually evolved. The older model focused on habituation. The idea was to stay with the trigger until your anxiety naturally decreased. But the modern and, frankly, more effective model is based on inhibitory learning. Here, the goal isn't to eliminate the fear, but to build a new, competing learning structure that inhibits the original fear response. You do this by systematically violating the feared expectancies. You're teaching the brain, through direct experience, that the catastrophe doesn't happen, and that the distress is actually tolerable without doing any compulsions.
So the execution of effective ERP has to be precise. It involves deliberately provoking obsessions, allowing that first fear response to happen without fighting it, and most importantly, systematically refusing to engage in any neutralizing compulsions. The focus shifts away from monitoring how anxious you feel and toward practicing a willingness to just be uncomfortable and to violate the expectations of the feared outcome.
So what's the outcome here? Well, the therapeutic outcome requires a redefinition of what recovery even means. Success in OCD treatment is not the elimination of intrusive thoughts. That's a neurobiological impossibility. It's about a fundamental change in your response to them.
This is such a vital therapeutic message. Recovery means that intrusive thoughts are returned to their proper status. They are simply irrelevant mental noise. They might still show up, sure, but they no longer have the power to derail your behavior, to demand a response, or to cause significant distress.
This slide really summarizes the entire journey. The OCD loop is defined by this feeling of urgency, a demand for 100% certainty, and a constant fight. Recovery, on the other hand, is characterized by a loss of that urgency. It is the ability to tolerate uncertainty, and to simply coexist with your thoughts without needing to engage with them, analyze them, or get rid of them.
You can think of the process of recovery as strengthening your own metacognitive awareness, what we might call the wise mind. This is the capacity to observe your own mental events non-judgmentally, recognizing that worried voice and the amygdala's alarms for what they are, passing neurological data, not objective truths. And this allows you to choose your actions based on your values, not on your fear.
Because ultimately, effective treatment for OCD isn't just about reducing symptoms. It's about liberation. It's freedom from the cycle of obsessions and compulsions. It is the reclaiming of your mental and behavioral freedom, allowing you to redirect all that energy away from an internal battle and toward building a meaningful life.